Welcome to part 4 of the acyanotic heart disease. We're going to talk now about the atrioventricular septal defect, AVSD. And please, I want you to repeat pronouncing things to yourself, because during the exam you get mixed up with saying atrioventricular septal defect, AVSD. Commonly seen in children with trisomy 21. It ranges from a primum type ASD that we mentioned before to a complete atrioventricular septal defect with a coexisting large VSD and single common AV valve. What is that? Let us look again here. An atrioventricular septal defect was previously called endocardial cushion defect, and because this name is a little bit strange, many of the students remember endocardial cushion defect, but they forget the AVSD. What are the endocardial cushions? During cardiac development, this is a cross section in the middle of the heart, and these are the endocardial cushions. A defect occurs in these endocardial cushions, and in endocardial cushion defect, there is defect in the lower part of the interatrial septum, defect in the upper part of the interventricular septum, and a common AV valve. So as you can see, this is a complex defect. This is not a simple defect. So in complete AVSD, we have a lower part ASD, defect in the lower part of the septum, which is a primum ASD, defect in the upper part of the interventricular septum, a cleft mitral leaflet, and a common AV valve is present. In the incomplete form, we have the ostium primum ASD and the cleft mitral leaflet. This is a diagram of the defects where there is a low ASD, a high VSD, and a common AV valve. This is an echo of the defect showing, look at here, this is a low ASD, a high VSD, and a common AV valve. This is an echo, and this is called a four-chamber view because we can see the four chambers of the heart. What is the clinical picture? What will that patient present with? If it's a partial atrioventricular septal defect, they may produce symptoms similar to ostium secundum ASD. A complete atrioventricular septal defect usually have symptoms such as failure to thrive, tachypnea, diaphoresis with feeding. What is diaphoresis? Diaphoresis is profuse sweating due to illness. It is not a normal sweating. يعني عرق مش بتاع عرق عادي، عرق بتاع مريض. And it occurs with feeding or recurrent bouts of pneumonia. So as you can see, complete atrioventricular septal defect have got more severe symptoms. By auscultation, the murmur is often inaudible in neonates because it is a shorter murmur than that of a VSD. Loud pulmonary component of the S2 is common. They are liable to pulmonary hypertension early in life, and that is very important. A parasternal systolic murmur that is not as harsh as that of an isolated VSD is heard. وهو عشان نفهم ليه الميرمر صغيرة، القلب لما الديفكتس بيبقى فيه كبيرة واسعة ده ما بيعملش ميرمر عالية. كل لما الديفكت ابتدى يضيق ممكن ده يعلي الميرمر. How am I going to manage such patient? We have to treat heart failure, growth failure, and chest infection. Surgical correction is more hazardous because of the complexity of the intracardiac repair. Children with trisomy 21 are particularly liable to develop pulmonary hypertension. هم العادي بتاع trisomy 21, they are more prone to pulmonary hypertension, particularly with their upper airway obstruction. مناخيرهم, they have a small nose, big tongue, they are obstructed frequently. And if they have an atrioventricular septal defect, so they develop pulmonary hypertension more quickly and easily. And atrioventricular septal defects must be corrected early in infants of trisomy 21. These patients also require prophylaxis against infective endocarditis. The patent ductus arteriosus. The incidence is between 5 to 10% of all congenital heart disease. The ductus arteriosus connects the pulmonary artery to the descending aorta. Failure to close shortly after birth frequently occurs in preterm neonates. لأن هي طبيعي تقفل بعد البirth بس لا in preterm it does not. In older children it is due to defect in the constrictor mechanism of the duct. What is meant by that? Look here, that's the ductus. It is connecting the aorta, look at the aorta, to the pulmonary. This is the PDA. When should it close? What is it doing, that PDA? In utero, it diverts blood from the lung to the descending aorta so that the blood can reach the lower limbs and the kidney. It is maintained by low oxygen and prostaglandin E2. In a full-term neonate, functional closure occurs few hours after birth. بعد لما الطفل يتولد وياخد نفسه، أول النفس الأولاني ياخد oxygen, increase oxygen، يقوم ده يخلي الكونستريكتور ماسل الموجودة في البي دي اي يحصل لها constriction وتقفل. يبقى هي maintained in utero opened with a low oxygen and it is closed with a high oxygen. But if it is still patent، يعني لو لسه مفتوحة patent يعني مفتوحة، that's a primary defect. يعني لو عندي سن أو لما بيبي يتولد وما قفلتش بعد أسبوع أقول لا ده primary defect ما دام هو full term. لو هو preterm هقول لا ده constrictor muscle not well developed and spontaneous closure might occur by 3 months of age. So although in the preterm it might cause very big problems, yet it can close spontaneously later on. So the PDA in the preterm infant might be suspected by bounding pulse and a systolic murmur at the left sternal edge when severe heart failure can result. But it is important to know that the PDA in a full term doesn't always exhibit this murmur, and we're going to talk about it now. Symptoms in an older child is like all the shunt lesion. It might be asymptomatic, or there is repeated chest infection, dyspnea, growth retardation, heart failure with the symptoms of heart failure, effective endocarditis and Eisenmenger. On examination, the patient has got a wide pulse pressure. You palpate the upper arm and you feel the difference between the systolic and diastolic, more than 40 to 50 millimeters mercury, and this causes a bounding pulse or a water hammer pulse, as you can see it in the arm. What do I find in examination? If I palpate, I can palpate a thrill here under the left clavicle or at the pulmonary area. You feel a continuous thrill, and by auscultation here there is a machinery murmur beneath the left clavicle. Machinery, if you hear it once, a typical machinery murmur, it is actually the one who described it was very close, because it is a typical PDA is like a machine. Both systolic and diastolic murmurs, look here, the systole and diastole, continuous murmur, and it is very harsh like a machine. That is in the typical PDA. Early in life, in the early 6 months of life, the systolic and diastolic element might not be typically heard together in these. Please listen to the PDA murmur here. The chest X-ray, like all shunt lesions, shows either a normal or an enlarged heart, enlarged pulmonary arteries, and increased pulmonary vasculature. The ECG might be normal, but it starts, if it's going to enlarge, showing ventricular enlargement, shows left ventricular hypertrophy with large to left shunts, and right ventricular hypertrophy with pulmonary hypertension may develop later. An echo, ducts are readily identified by cross-sectional echocardiography and Doppler, and this is a short axis parasternal view showing the pulmonary artery and showing the PDA, the color Doppler showing the PDA connecting the pulmonary artery to the descending, here is the descending aorta. am I going to treat the PDA? It closes spontaneously in most preterm infants, but if it is causing many symptoms, treatment with fluid restriction, diuretics, indomethacin, ibuprofen, or surgical ligation might be attempted. In young children with asymptomatic PDA, closure is recommended to abolish the risk of infective endocarditis. And if you read the recent guidelines, American Heart Association guidelines about infective endocarditis, you see that they are not mentioning PDA as an indication for infective endocarditis prophylaxis. In the Western world, they do not see infective endocarditis in PDAs. Here in Egypt, we have a different situation. We have seen many cases of infective endocarditis in the patent ductus arteriosus. This is an experience we've seen here at Ain Shams University, in Cairo University, in Alexandria, in all universities and all those working with pediatric cardiology. So there is a general agreement between pediatric cardiologists in Egypt that PDA needs infective endocarditis prophylaxis because it does occur, and we have seen many cases of infective endocarditis in patent ductus arteriosus. How am I going to manage? I can surgically ligate it, or very commonly now, it is closed by a device transvenous occlusion by a catheter. This is a coil closing the patent ductus arteriosus. So please be ready with your questions in the next face-to-face session about that part. These are the slides for further readings, and good luck.